there's one entity of fractures which is thoroughly overlooked and neglected, and these are pelvic fractures in the elderly. As you can see very easily, there's a strong age-related increase of pelvic fractures. And you can see here that in persons 75 years and older, the numbers of pelvic fractures is going up, and this is confirmed in also some recent publications. So recently we are facing, let's say, a tsunami of osteoporotic fractures, and especially also on pelvic fractures, where we might see in Germany more than 15,000 fractures per year, and in Europe similar numbers. So the problem with pelvic fractures in the elderly is that they are difficult to diagnose. The patient have immobilizing pain and mostly no adequate trauma due to osteoporotic bone, and so far there are no standards in treatment of these osteoporotic pelvic fractures. They are very hard to identify, and mostly the general practitioner, the general doctors, see these patients first. And if they really look at these patients, they might perform an X-ray. And in the pelvic X-ray in osteoporotic elderly people, these fractures very frequently are overlooked and not seen. So therefore, I strongly advise you to, if you have a patient who has symptoms of a pelvic fracture and immobilizing pain, you have to go further in diagnostics. Sometimes you might do an MRI, or you do a CT scan, and then you might have the diagnosis. The German Society of Trauma talks about the fracture which is completely neglected, and we see a strong increase of pelvic fractures, the sacral insufficiency fractures, which has first been described by Laurie in 1982. And you can see here very nicely the insufficiency of the pelvic area, which is here. So if you have a pelvic fracture and just a ramic pubi fracture in the elderly, mostly in more than 70%, I probably would say in more than 90%, the sacrum, because the pelvic ring is involved, is also has also a fracture. And I would like to show this in a case here. This is a very active 86-year-old patient, and he suffers after a fall from a bike, so it's a low velocity, low energy trauma. He suffers from immobilizing pain. And if you look closely, you can see that on the left ramic pubi, there's a fracture. Like here, you would see that here, you would identify this as a fracture, but the sacrum area is hardly to be seen. And in these patients, you have to perform a CT scan, and the CT scan shows you the reason for his immobilizing pain, and you can see here pelvic fracture, sacrum fracture on the left side. So these fractures also have been sustained by very popular people like our Chancellor Angela Merkel, who sustained a pelvic fracture, a sacrum fracture during skiing. So that was also a low velocity injury. And it remains unclear what type of treatment she should have received. She's a very powerful and stubborn lady, and she decided for conservative treatment. So these are the options which you have in order to treat these patients. And of course, conservative treatment is the first treatment of choice. But conservative treatment does not mean no treatment. So you have to give your patients analgesia. The patient has to be mobilized immediately with walkers and crutches, and this you perform during the first week. And if the patient remains with pain, then you should consider other options. And this is one option: conservative treatment, successful, let's say, pain management, and the patient can be mobilized in a good way. Another option might be open reduction and internal fixation with locking implants, like you can see here, which has been also advocated by my colleague and friend Paul Rommens from Mainz. And you might use even fixed angled plates, or another option might be a very rigid type of fixation. This might be a lumbopelvic fixation. But however, this fixation means a high rate of complication, especially in the elderly, up to 38%, like shown here in the literature. So another option of fixation to lower the angle and to lower the lever arm might be only a fixation of the sacrum and the ilium, like an ilio-sacropelvic fixation. A fourth option, which has been described by radiologists and which also has to do with augmentation, means a sacroplasty. Sacroplasty is actually, you see here, there are some papers from the literature in Germany where you just introduce a bone cement into the sacrum. However, this only should be done in non-displaced fractures and in occurring shear forces, which definitely have to occur during mobilization. These patients and these fixation methods are not so good. So I strongly advise you to perform a sacroiliac fixation, which I would like to show you here. The patient has to be positioned on the radiolucent table, and you need the option for later inlet and outlet X-ray procedures. And you can see in the lateral view, you really have to be able to identify the lumbo and sacral spine. And here, in different steps, you can see the guide wire, which is positioned into the right position. And later you just put cannulated screws, which are from different companies available, over the guide wire in order to make a minimal invasive but very effective percutaneous fixation. However, the setup of this is for the patient, of course, minimal invasive, but for us surgeons, it's a lot of technical and demanding things. You need a radiolucent table, you need a 3-dimensional image intensifier, and sometimes when it's difficult and you have obese patients, you even might need a navigation system to be really 100% sure where to position your sacral screw. And here the technique again, which is being shown, a minimal invasive but very effective percutaneous fixation, and we use a special 3-dimensional C-arm either from Siemens or from Ziem in order to get a perfect intraoperative visualization. And here you can see another patient, 62 years old, male, and he has a very high pain level after a fall of a low energy. And the additional problem is in this patient, he had a kidney transplantation. So he has a very difficult anatomy also. And in this patient, we perform the operation in the prone position. And you can see here that the screws or the Kirschner wires are identified three-dimensionally, intraoperatively with a C-arm, and then you can introduce your screws over these Kirschner wires. Another very obese patient, here you can see the dimensions in the CT scan and in the SCOUT, and she suffered from bilateral sacrum fractures, which have been fixed percutaneously with this navigation system. But after mobilization, you see on the right side an implant failure. So the question occurs, why not augment the screws like we have done this, or we are doing this on other regions like in the pelvis, in the spine, and in the proximal hip. And we have tested this in a biomechanical lab, and the idea is that you normally you have a backing out of the screw, and with augmentation in the distal part of the screw, you prevent the screw to back out, and you have a better anchorage of the screws. And we have tested that in our biomechanical lab and saw that the augmentation is much stronger than a non-augmented situation. And again, another patient, you see here low energy trauma, bilateral sacrum fractures, and you see here the technique which we are performing. While the screw is inserted, after the screw is inserted, we put in some contrast in order to see that the screw is in the right position. And here, the cement, which has a very high velocity, is prepared for the augmentation of the screw. And you can see here, these are the intraoperative steps of these special screws, which are then introduced through the Seldinger technology. The Kirschner wire is positioned under image intensifier, which you might see later on. You see here the navigation system. The screw is already in place, in the correct place, and then we perform with the contrast means, we perform the change to the perfect positioning of the screw. And here Kirschner wire is being used for the Seldinger technology. And you can see here the wire is now introduced, and we have a contrast measurement which we put into the pelvis in order to be sure that no veins are injured. Again here, the contrast medium is coming now. And you can see here that there's a good positioning, perfect positioning of the screw, and the contrast level is getting out. And now we continue. In some cases, in very obese patients, the cannulas are too short, so we have to take very long cannulas in order to have a good postoperative and perfect positioning of the sacral screw. And in some other cases, even in elderly patients, we combine this with anterior fixation of an supraacetabular fixator, which offers then immediate full weight-bearing situation for these old patients. In very rare patients, we see complications. That means a back out of the cement, but up to now, in more than 100 cases, which I have been done with this method, I didn't see any problems with the neurologic system. So here another patient who had persistent pain following a sacroplastia without fixation. And here we perform again a navigated bilateral fixation of the pelvis on the S1 and on S2 level in order to allow a perfect and immediate postoperative mobilization. So I would like to conclude, in pelvic sacroiliac fractures, The standard procedure in my hands is sacroiliac fixation with screws. You need intraoperative 3D imaging, and in the cases where you have a reduced torque while you introduce the screw, then later on you can proceed with augmentation in order to increase the stability. Molto obrigado.